This is Dr. Shamama, and today we're starting a new series, and this is going to be the first case of the case of each series. So it's a 4-year-old boy which presented with a swelling on the left lower side of the mandible. It started from the midline to the body of the mandible with a soft firm intraoral swelling. It started at 6 weeks of birth, and it rapidly increased in size over the last 2 months. This is actual, so all the pictures in this presentation are actually from the patient. CT scan was performed, which revealed 2 hypodense lobulated lesions, seen here and here. And within the left hemimandible, they raised the suspicion of an odontogenic cyst. Later on, incisional biopsy was performed, and it revealed this soft to firm extensile lytic bony lesion, and it was bluish to blackish in hue. I hope it's clear in the image. It was adherent to the overlying mucosa. So far, the clinical differential diagnosis of odontogenic cyst, Langerhans cell histiocytosis, infantile fibrosarcoma, and congenital epilis were made. After it, the sample was sent for cytology. FNAC was performed, which initially revealed clear fluid, probably leading to the cystic component of the swelling. But then on deep aspiration, it was blood tinged, and that revealed that it's probably some solid components within the swelling. On cytopsin preparation, it was revealing inflammatory cells with some lymphocytes and neutrophils against the proteinaceous background. It was negative for malignant cells, so we proceeded to the histopathology. We received multiple tissue fragments which were 1 centimeter in aggregate. Now I proceed with the microscopic images. So this is the first low power image. It was a skin covered tissue with some underlying neoplastic process going on. When we went on higher power, it revealed a fibrocollagenous stroma if you see around it. And if you just see on this image, you would actually appreciate even the first years that there are like 2 different kind of population of cells. We see here some small hyperchromatic bluish cells, and here we do see some nests and groups of cells with some pigment within their cytoplasm. This is another better image, but with lots of crushing artifact within the small hyperchromatic blue cell population. I have a better image of it. So here we can actually appreciate its cellular definition. These are the small blue cell population. They have a round nucleus, very hyperchromatic, and we see very scant cytoplasm or even no cytoplasm in many places. But when we compare it with the second population of cells, we do see that they have a larger size as compared to the previous cell population. They have a larger nucleus, which is less hyperchromatic. It is vesicular chromatin, and we do see abundant cytoplasm, which we appreciate here. It's all cytoplasm here. And then here in the cytoplasm, we see some brown pigment. So that's why we're calling it the pigment-containing population. And this is a better image for you guys to appreciate the clear 2 population at a higher magnification level. This is the small round blue cell population. Here are some nests and groups of the pigment-containing cells. So now I would like to ask any possible differential diagnosis you all have in your mind, and if you want any answers for the stains to rule in or rule out any diagnosis. Any thoughts?
पहले तो रेजिडेंट्स अगर बताएं तो फिर जी बेटी नहीं आप तो नहीं आप तो नहीं बता
So identity is excluding Melanin charge.
रेजिडेंट्स
Yeah.
Stain one.
स्टेट्स बता
Or any thought, like just from the small round blue cell population, you have a differential in mind.
Biphasic population से hint
Yeah. So anything from the small round blue cell population you guys have in your mind. Like exclude the 2 cell population. You can go for either single population.
S100.
It was negative.
S100 for what? शाबाश ठीक है गुड थॉट लेकिन क्या जेन में melanoma very good
Melanoma is a good differential, yeah. So you can think melanoma based on the pigment containing population we have here. Now, any differentials in the small round blue cell population? A good thought. I heard synapse or something like that. It was positive. So it was positive in one of the population and negative in the other, just a small negative. It was a mandible swelling. Just a thing lymphoma from small round blue cell. Yeah, that's a good thought.
एज के हिसाब से
Yeah.
एज और लोकेशन के हिसाब से
So let's go on to the differentials.
So rhabdomyosarcoma was a good differential. I'll explain in a minute. So now, since we had two population of cells, so we'll think of differential based on both of them. So first four differentials would be on the small round blue cell population. First comes in our mind is Ewing sarcoma. So it does have the small round blue cell tumors which grows in sheets and nests, but it lacks the epithelioid component, and it should have the Ewing sarcoma 1 rearrangements, which is not present in our case. So that rules out our first differential. Moving on is olfactory neuroblastoma, again on the basis of the small round blue cell, but interestingly, it imparts the biphasic morphology by having the homoerite rosettes in it, and synopter, which someone said it is positive in our case, and it's also positive in olfactory neuroblastoma. But we differentiate on the basis of the second component, which is the epithelioid component. It's not present here, and then on the basis of the age. So olfactory neuroblastoma presents in the later stages of life, in 5th and 6th decades of life. Although our case, its median age would be less than 1 year, but it can occur up to like 5 years. Third differential is the desmoplastic small round cell tumor. Again, on the basis of the small round blue cells, but still it lacks the epithelioid component, and it can have the Ewing sarcoma 1 rearrangements as Ewing sarcoma, but this is how we differentiate it from a current 290. Rhabdomyosarcoma is what is said. So yeah, it is a differential based on the small round blue cell, but it lacks the epithelioid component. In addition to the round blue cells, we do have some scattered rhabdomyoblasts, and interestingly, we can differentiate it by the stains. It would obviously be positive for the myogenic markers, which are myogenin and myod1, and they are negative in our case. Lymphoma, that was I was saying that whenever you think of small round blue cells clustered together, we think of lymphoma. Here, the most common two lymphomas, which are differentials of our case, is lymphoblastic lymphoma and Burkitt lymphoma. Because of the round blue cells and because of its location, because lymphomas are also mostly on the jawbones. But it lacks the biphasic morphology, and on staining, PDT would be positive in case of lymphoma, but it would be clearly negative here in our case. Melanoma, as Dr. Diveria suggested, because of the pigment-containing cells, because of course we have to think about the second population too. So it does have the pigment-containing cells, but it differentiates. So thing of melanoma is that it can take any kind of morphology. So we can't say here that it lacks the epithelioid component, because you never know in any case it has the epithelioid morphology. So difference here would be it lacks neurotization and any atypical mitosis. After it, the stains we did on our case was cytokeratin. It was positive. Here you can clearly see it's positive in the overlying skin, and these are the two population of cells. I've already shown this image before. So this is positive in large epithelioid cell population, but it's clearly negative in the small round blue cell population, and it has a cytoplasmic staining pattern. Synapto, as we were discussing before, it was positive in our case, clearly in the round blue cell population, and here these are the large epithelioid cells. We can identify by the larger nucleus we discussed before. So here, don't get confused with this brown pigment you do see here in these cells. It's not actually the synaptophysin, it's basically the pigment we have in the cytoplasm of their cells. So basically they're negative. So we did few more stains. I don't have a clear images of those. I can share them later on after the presentation. So HMB45 was done, that was positive in the epithelioid cell population and negative in the small round blue cell population. S100, we were discussing before, it was negative in our case. And chromogranin was done, which was also negative in our case. So these were the two negative stains and the remaining were the positive stains. So the diagnosis eventually was Melanotic Neuroectodermal Tumor of Infancy. Has anyone heard of it before?
It's a very rare case, but a spotter for those who have seen it once. एक दफा आपने देख लिया, आप इसको without markers आप identify
So I'll proceed on to the literature review briefly. So I've explained majority of the case already. We'll just briefly go through the whole story of the case. So it's actually a rare tumor, as Dr. Sayed said. Till now, after all the literature search I did, it was up to just 500 cases reported so far. And only 3 cases were reported from Pakistan. Firstly, it was in 2013 by Aga Khan University. It was in an 8-month female with swelling on the anterior parasagittal skull. Later on, by PIMS, Lahore General Hospital, 2 more cases were presented in 2025. And after it, till now, no further cases reported. So this is going to be a little bit interesting. Talking about history of this entity. So basically, the first case was identified in 1918, and 1966 was the first time when its actual name was named. So what interesting is about this case is that throughout these years, it has gone through evolution of its name, basically based on periodically how the pathologists were understanding its exact origin. So first of all, Prompetcher identified the first case in 1918. It was in a 2-month-old boy, and swelling was on the maxilla. They saw something related to melanocytes, so they call it congenital melanocarcinoma. That name switched to melanotic epithelial or tumor, probably because they identified the other cellular component in it in 1926, switched on to retinal enlarged tumor and melanotic adamantinoma. Then what interesting happened in 1956 was by Misugi et al. He first time went a bit closer to its origin, which is neural tissue. Later on, switched to melanotic endoblastoma and melanotic prognoma. And then finally, in 1966, Burello and Garland, they saw a case which was a 3-month-old girl. It was an anterior maxillary swelling. So what they saw was that before operating the swelling, they did their urinary vanillyl mandelic acid levels, and they were pretty elevated. But when they checked those VMA levels after the surgery, they were drastically decreased. So what they thought was that probably it's something related to the neural crest origin as pheochromocytoma, because VMA is elevated there. So from there, its origin was firstly identified, and that gave it the name Melanotic Neuroectodermal Tumor of Infancy till date. I mean, you never know, after a couple of years it would eventually change too. A brief review on its epidemiology. It would be a rapidly growing benign tumor. It originates from the neural crest, the VMA thing I've already told you before. It typically occur in infants, as you clearly identify by its name. Median age is 5 months, and there's a slight predominance seen in males. Most common sites here, so far in literature, it's the craniofacial region. More than 60 cases in the maxilla can occur in mandible too, but it's pretty less, up to 7% I would say. And if it's outside the craniofacial region, it would be testis and epididymis, and very rare, I did saw some of the case reports which were in the female reproductive tract. Now, I would just like to briefly explain how this originated. Obviously, everyone of you would know about how neural crest and neural tube forms, but just a brief review I made here. So this is how the mesoderm stimulates the overlying ectoderm, invaginates it, forming neural folds and neural grooves. Eventually, the neural fold which forms the neural tube in the center, closing the pores, and these green are the neural crest cells, which migrate outward, and eventually they form our origin of our tumor. Neural crest also forms dorsal root ganglia, Schwann cells, melanocyte, craniofacial skeleton, peripheral nerves, and adrenal medulla. Just a brief highlight, which is my thought process, any senior can correct me out, that probably because of that it has like a melanocyte type population, it has a craniofacial origin, most in location, and VMA levels because of the common origin from adrenal medulla can be corrected by any of the seniors. So, how we diagnose this entity? Clinically present as a rapidly expansile mass but mostly the diagnosis is based on the hallmark histopathologic finding, which is the biphasic population of cells. I've already explained you this whole thing, but this was actually our case, and now I would say that you can actually implement your whole knowledge, seeing the biphasic population, and if you see later on anytime in the coming years, you would not take like more than a minute to identify the case. And it does have some background dense fibrosis, which creates a look of like a third type of population, but actually it has two populations. Just a brief summary of the immunostains we do here. Negative stains are S100 and chromogranin. The positive stains, I would like to just say that you can remember based on the both populations. So this brown blue cell population is positive for synaptophysin, neuron-specific enolase, GFAP, and CD57. While the epithelioid cell component, as I showed you before, already cytokeratin is positive and HMB45 is positive there. A little bit on its molecular and cytogenetics. So it does have a germline mutation of sericin2A, but lately two new mutations have been seen here, which is RPLP1, C19 MIC fusion, and BRAF V600E mutations. They are seen in 1-1 cases so far in literature. If anyone is interested, you can see through the references. So overall, the prognosis of the tumor, it's an excellent prognosis, and after complete surgical excision, there is a long-term survival expected in these patients. But recurrence can occur, although less, but in 10 to 30% of the cases. And time, it's this up to 6 months after surgery. The main risk factor is that if the tumor is not completely surgically excised, or if we left some positive margins behind. Metastasis is very rare. It is up to like 3 to 7% of the cases. But if it occurs, it would go in liver, lymph node, bones, and in the mediastinum. The adverse prognostic factors would be young age, Ki67 higher, if it's a very rapid growth or it's an extensive bone invasion seen. So probably the last slide obviously, it would be, why we're discussing this case here, as Dr. Sarah told before, it's a very rare case, and we have a spotted histologic morphology here, so it's important to worth mentioning with everyone. So if they have seen once, whenever they would see again, they won't have any time to identify it. What are our future goals regarding the case? We are preparing a case report and literature review on it. Interestingly, how our case is further rare from the normal rare entity is that normally it's in less than 1 year of age, but clearly our case is more than 1 year, it's in a 4-year-old boy. Makes it further very rare. Additionally, most commonly from the craniofacial region, it occurs in the maxilla. So very few cases, like up to 7% have been seen in the mandible. So our case would be probably an addition to them, and that makes it an ultra rare case presentation. So this is our topic. We are thinking to write an article on it. It's beyond the pigmented maxillary mass, Melanotic Neuroectodermal Tumor of Infancy, histopathological pearls, and literature review.